Hey, everybody, welcome back to the Overrun on YouTube. I am joined by Dr. Jaime Myers, an associate professor of public health at Monmouth University, my alma mater. And today we're going to talk about some epidemiology for EMTs. Hi, Dr. Myers.
Hello.
It's good to see you. So in EMS, there's almost no time spent on epidemiology, yet we do talk a lot about studies and different types of data that have come out. So I wanted to kind of talk to you for a bit, just to kind of get an idea of what EMS providers should look for when they're looking for data. Specifically, because we talk on the show a lot about, a study came out and it said this, but I don't know that it translates very well. So if I'm an EMT, if I'm starting in EMS and I'm starting to look at data, what are some of the important things that I should look for?
So the big studies are going to end up in the popular press anyway, right? The ones that are groundbreaking and the ones that have really strong findings, they're going to get reported in your New York Times. They're going to get blown up. And so it's very easy, even if you don't go to the peer-reviewed literature yourself, to find out about those big findings through the popular press. If you just honestly want to learn new things and stay abreast of things, setting up a regular Google search for the standard news out of reputable sources is a really good place to start, even if you don't want to get into the nitty-gritty of maybe statistics or study design or any of those other things. So you will get a really good, easy to understand translation from the scientific writers in those popular press mediums. So if you really want to have the entry level, that's great. Right? If you're trying to tackle the peer-reviewed literature though for the first time, you would be not remiss in being like, everyone finds this a little dry, and why do they write it this way? Even those of us who love to read and learn and nerd out on these things can find the studies as they're presented to be kind of boring. But
it can be tough to read, right?
Right? And there's a good reason for that, is because they want to make sure that you have all the essential information to figure out just how good that study is and how strong those findings are. And so there's a standard format in which we present that, right?
Right. And I agree with you. I think academic writing can be very difficult to, not so much difficult to read, but difficult to kind of keep up with. And I do think it's good that there are popular stories that go out. Obviously, in the culture we're in, there's a lot of resistance to reading popular media because everything is biased or whatever. So touch on what is it in your mind that makes a good study? Because I think that's something we've talked on the show with Ken Milne before, where this is a good study and it shows this, but what is it that in your mind makes a good study?
Okay, there's a couple of factors if you want to look at a quality of a study. Obviously, their methodology. How did they get participants and what did they do with them? For instance, is it an actual experiment? Is it quasi-experimental, where there is a control group and the researcher has control over who gets what medium, and then we test beforehand and test afterwards and see whether or not there's a change? Obviously, those types of studies tend to be what we have as the epitome of research. However, in the healthcare field, a lot of times we can't do those because the things we want to study are the things that hurt us. If we think it's bad to smoke, we can't tell people, hey, you're in the smoking group now.
Yeah, give it a shot, smoke for a couple months, see how you feel, come on back.
Exactly. And so, especially in epidemiology, because epidemiology is largely what we call an observational science. We basically study people as they're already doing the things they're doing, because it'd be unethical for us to actually assign them to do those things. And so in those experimental studies in my field, in health in general, you can only do things you think will have a positive outcome, which really makes studying a lot of those risk factors, or the factors in health that we think are detrimental, harder to do. And so
sure. And there's a lot of studies too that, and something around 90% of medications that are put out to the field fail before they actually get out to the actual like retail sales. And so again, it's important where like a study can also show that something is negative, right? It's not, studies aren't always, we did this and it worked and everything is great. A lot of times this doesn't actually work. So talk about inferiority and non-inferiority. Or it doesn't work better, right? Exactly.
Right? Like, it's better than the standard of care that's currently going on. This doesn't exceed that in any meaningful way, and it's more costly, and it's XYZ.
Right. So talk about inferiority and non-inferiority, because I feel like that can be a bit confusing for people when, seeing a study and saying this is inferior to this is it's a pretty obvious way to state something, right? But I feel like if you're going through different types of drugs or treatments and says one is non-inferior to the other, what does that say to you when you're reading that study?
It says, is it cheaper? Is it easily accessible? That's what, honestly, from a public health standpoint, at that point, if we have equivalent drugs that could be available, I now want to know which one's easiest to produce and cheapest to provide, right? Because if they have equivalency in that regard as far as outcomes go, then let's throw both on the market and see who wins in the market race as far as economics go. Unfortunately, that doesn't tend to be the case. Those who are non-inferior often don't get released because the other person already has too much of the market share as far as
Right.
advertising and publicity, especially coming out of pharma, if that's where you're looking at. Those drugs often don't end up on market just because it would take too much to launch and then fight for their market share if they're not better. And so they
Right.
don't
And then you
tend
get
to.
and then you get drugs that are so cheap that they almost end up becoming orphan drugs. So there was, there's been a debate in EMS and in emergency medicine over lidocaine versus amiodarone, where amiodarone was a publicly or a privately created drug that had profit margins. Lidocaine cost $1 and was made generically. So companies that have this type of money and funding to go into research tend to also kind of get things published a little bit more, I think, sometimes. So if I'm reading through something and I want to know, how does this intervention, this drug, make a difference? What's the tangibility of that? When I'm looking at number needed to treat, talk about how that affects the study and how that might affect things moving forward after the study is completed.
And so while I can talk about that, that's not really how I look at it in my studies. Number needed to treat is definitely used more in the medical field than in public health. The
Sure.
idea behind number needed to treat is how many people do we have to give this to actually save that life or improve that person. So for instance, if I have a drug and I know it works for every 60th person, my number needed to treat to cure somebody is number 60.
Right.
And so you don't want a drug that you have to wait, especially if it's expensive or time consuming or invasive. You want that number needed to treat to be something that is reasonable for the expenditure for all those people it didn't work for. Right. And that's the idea behind that concept. The way that I often look at findings is about how big are the confidence intervals on how many people this actually works for, right? Is it one of those things, maybe, and that's a statistic you could use. For instance, if the number needed to treat has a huge confidence interval, AKA, the real number of people could be between, let's say, 30 and 80, but we say our number is 60. You're like, okay, well, if it's 30, that's great, and 80, but that's a lot of error around this.
Right.
And that makes it a less good study, right? If you have a good study and the number needed to treat comes out as, let's say, 15 for something terminal, that's a great answer. If every 15th person this works for, let's go for it, right?
Right.
However, if it also said the answer could be between 9 and 100, you're like, wait, what's going on here? Right? And so when you get those statistics, really seeing the variability around those statistics talks about how strong that study is. And that normally comes down to the number of people they had in their sample.
And so generally speaking, you want a larger sample in your studies, right? Especially if it's observational. So you want to have more people to know that this intervention or this observation actually made a difference.
Yeah, and so when we're talking about observational studies, if we're looking less than 2,000 people in it, you start to question, what are we looking at here? You also get to the other side of it, though. If you have too many people in your study, everything's going to look significant. And that's also a thing, so.
It is trying to find a balance. I'm just looking this up now. The number needed to treat for aspirin seems to be 50, which is another interesting conversation about the use of medications that we use. So when talk quickly about how studies kind of come together, right? Is it the, I guess, is it just, it's as simple as we have a question, let's go try and find it? Or what are the steps between, and I know experimental, you have to go through an IRB and like that, but just real quick, if I wanted to do a study myself, how would I start that process?
Yeah, so a lot of these studies, the more robust studies, the ones that we actually want you to pay attention to, have already been studied in ways we find less scientific. And by that, less trustworthy, less likely to be implemented. More, hey, we see a pattern here. Maybe we should study this further. And so
Right.
originally, we'll do some cross-sectional surveys and we'll see some patterns in the data and we'll see some associations. But if anyone's taken intro level stats, association does not equal causation. And so those initial robust surveys that we can go out there and look at, and those big public data sets that are available to you from the CDC and the National Center of Health Statistics, you could start playing in those and seeing if you have any connections. But at the other end, you're not going to use them for any clinical ramifications, right? And so what we normally start with is, hey, we have a hunch. We either do a small scale study because it is so necessary. There are no other options for this. Like, it depends on also how critical the condition is. Or more commonly in public health, we start fishing in the data. And then after we see a pattern, we might create our own survey to see if that pattern does have a strong connection. If we see a strong connection in that kind of study, we might do a more robust study like a case control study or a cohort study. By the time we're at a cohort study, which is still observational, where we do not control who does get the intervention or doesn't, when we get to the point where we're following you up and or are able to go back through your medical records and have a longitudinal data set with saying, hey, this thing has an impact, we are now at the big money of science. And also pretty confident in the conclusions because you now have that longitudinal data and know when that exposure had a health effect. And so when you get to those really well done, and initially there's probably smaller cohort studies because it's very expensive to follow people over time. And so if you have some robust data there, one of the areas that's really getting interesting, especially with big medical records, is that Europe is doing really amazing cohort studies retrospectively, where they're looking inside of the data that's already been collected through their medical histories because they have a singular national health system that collects all this data. And they're able to now do some really good retrospective cohort studies for much cheaper because typically when we do them prospectively and see it like follow people into the future for 30, 40 years to see if they get heart disease, like Framingham, they cost a lot of money.
Yeah, and just for the listeners, Framingham is a heart study that's been going on in Massachusetts for 60 years, 70 years now?
Since 1943, I believe, off the top of my head.
More, yeah, so 80 years.
46, 43.
But it is a longitudinal set based off of one town. And it's a very important study group that continues to publish. And it's actually kind of where we've gotten a lot of our information about heart health, which is great considering that, I feel like we look around at academic institutions to kind of get our information and data. And there's just one town that's kind of been just giving us all this data for all this time. When we're looking at data sets, one things, and you and I have talked about this off air, but one thing that I kind of like are meta-analyses where, it's more like a study of studies. So one of the things that happens a lot in medicine, especially with treatments or interventions, is at the end, your sample size tends to end up being sort of small. So, if I'm looking for a certain presentation on, say, aortic dissections, in 5 years, my center might only have 7 people who have aortic dissections. So we want to put out a study. All right, we're putting out a study with an N of 7. But then a meta-analysis will go in and take 20 studies that have 7 people and kind of look at the data from there. So talk a little bit about the value that meta-analyses have and I guess their positioning on the hierarchy of good and bad data.
They are actually considered top tier when they're done well. The problem is to do a meta-analysis really well is very challenging. Why? Because if you want to collapse all of those studies and say, hey, we have a singular sample here, you need to make sure that the methodologies in each one of those individual small studies are consistent. And that rarely happens, right?
Right.
And then you have to see whether or not they measured their outcomes the same way and at the same time frame. And so good meta-analyses that really have conclusional data associated with them are challenging to do. What is better is if you have a multi-center study that you set up initially with the same protocol so that your N of 7 at your institution gets another 18 from another and another. That is the better way to do it to ensure that the conclusions you're going to have. But we can't always do that, right? And we want to be able to pull in the aspirin study from 1970 with the 2023 study. And meta-analyses can do that to some extent, right? And the idea is if we see that there are similar measures, and that's one of the things, similar measures, similar protocols, we can then see across those studies, we do statistics across them to see, okay, what was the effect across these studies? What was the intent to treat? What was the what was the benefit across them? And so at that point, you can start to see a pattern. Okay, one study found 75% of people responded well. The next study found 28% of people found it like, and so you start getting an actual number between those studies that shows probably the effectiveness of that thing. They
So
are
it's
considered like the top tier, but they are very hard to do, and they are very hard to do well.
They're the top tier because they're the hardest to get done, right?
Well, they're also they have rigid protocols, and they're also collapsing data from many different studies. So any irregularity maybe in your sample, it honestly comes down to sampling. In those
Right.
kind of studies that you're talking about, so often it's a convenience sample or a simple regional sample, very little diversity in population. And so when you start building these things and you get someone who's from LA pairing with someone from Alaska, pairing from someone from Argentina, you now have more diversity of population health, right? And
Right.
so those
What it's more likely
individual,
to do with the group people.
right?
Yeah.
And especially because half the studies were done for forever on just men. And we know that finding racial diversity in a lot of these studies is very challenging because of reticence with the healthcare community and doing experimental trials amongst people of color. And so when you start putting these things together, you can start getting a more robust, more population level understanding of it.
It's more like casting a wider net to try and get just a better idea generally, right? Like if you're going to try, like it's a crude example, but if you were going to, if you're painting your house, you want to go to a bunch of different paint stores and get samples to have a better idea of what you want to do, So when I think of meta-analyses, that's kind of the idea I get, where instead of seeing one study, as a pillar, you can kind of look at the general opinion is probably that this is what happens.
Well, and you can get that from a systematic review, right? If you just compare and contrast across studies, anecdotally, and look at the different things and compare them, you can get that through that kind of study design too, which is like the difference between a meta-analysis though, is that then you're running statistics on that data, right?
Mm-hmm.
So you're getting all the data across those studies, you're pulling whatever's publishable and equivalent to then get an idea of exactly what is specifically when you're thinking about risk assessment, right? And you're trying to figure out, okay, what's the probability of heart failure if I provide this treatment? And you have 7 different studies and they're all having very different outcomes. The idea of the meta-analysis is that it can reduce the error in each of those individual studies by collapsing them together.
And again, while I'm a fan of systematic reviews and meta-analyses, I think something that happens in medicine a lot is a study will come out and it tends to be kind of advertised as, like, this is a game changer, this one's different. And I think that has a lot to do with, how social media affects medicine and like that. But talk a little bit about, I guess, do you feel that there is a danger to seeing one study and thinking that is kind of like the way to go? Or how would one, I guess, how do we kind of condition ourselves to not look at one study and think that is the absolute truth, and then, kind of keep our minds about us as we go through different data?
Well, that also, going back to what we already talked about as far as quality of that study, for instance, if we're doing a longitudinal cohort design and threw $50 million at it and been following it for 50 years, if it has a bombshell breakthrough, it's probably a bombshell breakthrough based on the robustness of that study design. If we're back to where your N of 7 has this new treatment, I would say buyer beware, right? That might be doctor specific, that might be patient population specific, that might be 10,000 other things. Maybe during that time, they also got all the emotional counseling in the world, and it was the fact that they were happier that you had better outcomes, right? It could be any one of those additional variables in that single protocol. When you're talking about these large scale studies that are built on those smaller scale projects, though, that are followed for very long periods of time and or have consistent results with large samples, then the bombshell is the bombshell.
So generally speaking, what you want to look for is a good sample size, right? You want to know if the question is, and our friend Remily Crow will say this too. She wants to know, if your question isn't good, there's no value in actually doing the study. So I guess the last thing before we get out of here is, how do you come up with a good question in a data set?
Research question for a study. Oh, I mean, you're in a clinical mindset, and that's a little different than mine tends to be in the public health mindset, because I immediately would go, you have some everyone has a hypothesis. It's probably built on some kind of stereotype or some kind of pattern you see out in the world. A lot of times, especially now in the world of big data, there's some data out there that you could start playing in and seeing if that pattern holds true outside of your own eyes, right? And then if you start seeing that pattern from beyond I know a guy who, if you can start seeing that pattern
The plural of
elsewise,
anecdote is not data.
right? But if you start seeing some patterns either in a data set that's already collected, or if you want to collect some initial data on something, that's a good way to start really forming a research question, a research agenda. By the time you're at clinical trials, you are so far past the good research question, right? The good research
Right.
question comes in out of testing your own assumptions right now and see what everyone else has already done on it and what's available for you to kind of feel out whether or not your assumptions are correct before you start doing anything higher level and far more expensive.
I think all that's right, and there's certainly further conversations we can have about what starts and stops studies from getting published, and all those other variables as well. But Dr. Jaime Myers from Monmouth University, thank you so much for this quick lesson. I appreciate it. I'll give you the last word, and then we'll get out of here.
Oh, I don't really have a last word, but thank you very much for having me on. This is my very first podcast, so thank you for the wonderful experience.
Welcome to the fold. Everybody make sure you like and subscribe down below. And for the Overrun, I'm Ed Bowder. We'll talk to you all next time.